So this is essentially just an extension of the other lectures that I think John has mostly done and Dr. Mulder. And so he asked me to kind of participate in the lectures and see if there's some things that I could add to the conversation. So my main goal really is two things. I think it's to introduce some new topics to some of the fellows and some of the other people joining the conversation, but it's also to touch on a few topics that we kind of talk about quite often, but I want to hopefully add something new to the conversation, but and then also review some of the basic kind of pharmacology of some of these drugs. And so that's kind of the intent of this lecture. So I will move forward. I have no disclosures, but the learning objective, so I have 6 topics that I was hoping to touch on. And the first one is low-dose naltrexone. That is a drug that I'm not sure many of us know a lot about. I did a lecture on it a couple years ago. And so this is kind of a condensed version of that. And I'll kind of just touch on some of the highlights and talk about some of the experiences that I've had. I want to talk about tricyclic antidepressants and NSAIDs. I feel like this is 2 topics that I have some opinions about, and also ones that we use or at least see quite often, but we don't always talk about. The next topic will be a conversation about a study that we presented to our team at Trinity, and it's I thought a very interesting study. And part of what I think when we're asked to see somebody, when we're consulted, at least in the inpatient service, and even on the outpatient, I think we're really asked to do something more than what other physicians will do, other providers. And so this is kind of I think a neat study. And so it's a way of fine-tuning people's pain management. I'm going to talk about tramadol, which is also a topic that I've seen brought up quite a bit. There seems to be a lot of strong opinions about tramadol. Some people love it and some people hate it. And so I was hoping that we could have a little conversation about that and some of my experiences. Lastly, I know this was touched on some of the other lectures, and it's just non-pharmacological treatments. This is something that I've been interested in for a long time. And so there are some resources that I think would be valuable to other people. And I think it's a good way to end this lecture because we rely so much on medications, and sometimes, at least in the inpatient setting, it's difficult to rely on the non-pharmacological treatments. But I think if we at least have this idea in our head that this is a way to treat patients, I think it's going to help people, because you're going to recognize when drugs and medicines have their limits. And that's really important. That's one of the things I think I've learned in my job is one of the hardest things to realize is when drugs aren't going to help somebody, or at least it's not the full picture. We'll start with low-dose naltrexone. Started the slides with this, and I'm going to end with it because I think generally when we're talking about new meds, I want to just convey simply what should be remembered about this drug. This is kind of the most important facts. So the dose is typically 4.5 milligrams that is given nightly. So it is quite low dose compared to other uses of naltrexone. It's used to treat primarily chronic pain, but it's been shown to also potentially help with fatigue and mood. Side effects are pretty minimal. And the biggest side effect that I've seen is vivid dreams, but there's also abdominal pain, nausea, and headaches. These are side effects that we generally see with almost every med. And then lastly, probably one of the most important parts of this is that it's a compounded medication. And so that is important to realize. Let's talk about some general pharmacology of naltrexone. I think it's a very interesting drug. It's a non-selective opioid receptor antagonist. So it blocks the mu receptor where most of the pain management occurs, the pain relieving effects. And so already you might realize the question is, how is this going to help with pain? And so we're going to get into that a little more. And that's what I think makes this so interesting. But you might have heard before people say it's the dose that makes the poison. And I think that's really true here because dose is so important. And a small dose may give one effect, and a large dose may give a completely different effect in the body. And I find that incredibly interesting. So Generally, it's been traditionally used for addiction, and that is in doses of 50 to 100 milligrams. It's very similar to Narcan. It's just got a little longer half-life. And we use Narcan to reverse opioid side effects. And so I think that's important. The dose here is 50 to 100, whereas the low dose naltrexone is a tenth of that dose, maybe even smaller. It's metabolized in liver. As I said, low dose can refer to 4.5 milligrams, but it can go as low as a half. And some people will elect to even start that low. There is also ultra low doses or very low doses, and that's seems in the research that I've seen, the studies, that's probably around 100 micrograms a day. I won't be talking about that at all here, but I think it's worth noting because there are some studies where they've combined naltrexone, very low dose, with opioids, and it has shown, it's been used in Europe, and it has been shown to have some interesting effects. It can minimize some of the negative side effects. I don't think it's fair to talk about low dose naltrexone without talking about some of the limits, and um, and so that's kind of, I want to be able to make sure that I address that. And on the left hand side, this is just a random website that I found, and it's when you do research and when you look up low dose naltrexone, you're going to find a lot of websites like this one on the left, and I think this is sort of a red flag for me because there's a ton of stuff here. My idea about this has changed a little bit though, because when you think about a lot of meds, for example, steroids, they have general effects for a lot of different conditions, just based on the mechanism of reducing inflammation. And I think that this is similar. But with that said, you'll notice like the first thing on this list is autism and cancer. And it's important to know that these things aren't going to fix that. That to me we should be careful of that. And so what I've done is I paired it up with the statement with the MS Society's website, and I think this gives a very appropriate approach to thinking about low dose naltrexone. And I've highlighted some of the points on there. So they basically say that low dose naltrexone has really honestly some limited clinical studies. They're mostly small, non-randomized control trials. And of the ones that they've completed, they have shown that it's been safe. It's easily tolerated. That's important because it does allow us to feel a little more comfortable about trying the drug if we feel that it's appropriate. But and then they continue, but few studies or a few of these studies show improvement to the actual disease process itself, and that's really important. It may help people feel better, but it may not actually help the actual underlying problem. And they continue that some studies have demonstrated improvement in quality of life, particularly in pain and fatigue management. And I think that's because some of the initial studies that were done were actually done for fibromyalgia. They've done it since then for a number of autoimmune disorders, Crohn's and ulcerative colitis. And I think I've seen some stuff for some skin conditions. And so we'll keep moving on. So let's talk about the actual, a little more detailed pharmacology. And I think there's some really, quite honestly, some interesting stuff here. As I mentioned, it blocks mu receptors. So the question becomes, how does it treat pain? If it blocks mu receptors, we know that if we give somebody Narcan, it reverses all the opioids that we've given them. Well, as I mentioned, it's the dose that's important. And so when we give a dose of 4.5 milligrams, it is such a small dose that the way I see it is that it kind of actually tricks the body into thinking that it needs to upregulate its own endogenous opioid system. So these are the things like endorphins. And endorphins are what we typically think of endorphins as like a runner's high. So you can imagine if we're producing more endorphins than we typically would, it's going to make us feel a little better. It's going to make the pain go down, and it may actually treat some of the depression. And we know that when we give opioids, sometimes people get more energy, sometimes their mood improves, and it's not, I think it's independent from the actual pain relieving effects. The other way that it treats pain and mood and things is through modulating glial cells. And I remember the first time I was reading about low-dose naltrexone, and the author kind of said, well, this is a very novel drug. We never had a drug that modulates glial cells. And so I think that's very interesting. And there may be a future in this in terms of um, finding other drugs that do this. Glial cells are typically in the brain and the nervous system. They're things like the Schwann cells, astrocytes. Uh, they're the cells in the brain and in the nervous system that help provide support, nutrition, repair, homeostasis, part of the immune system. They serve a really broad but important role. The other way that it has its effects is through these dopaminergic receptors. To be honest, when you read about this, it's not a very well understood process, and it's quite complex, to be honest. But ultimately, it affects dopamine, which may potentially help or aid in its effects with mood, which I think is important. So it's got multiple effects. The first one we talked about through the endogenous opioids, I think that's probably its primary effect in the body. This is a screenshot I took from Stanford's website. This was actually the first time I had heard about low-dose naltrexone. And it was through a very small study that Stanford did. And they did it with fibromyalgia patients. And so that's what I wanted to, since I had limited time to talk about low-dose naltrexone, I thought it would be helpful to just kind of show you the history of how this drug has been studied and where it started. And you'll notice that the dates are back to 2009. And so it's been known, it's been around for a while. It actually goes back further than that, but it hasn't really been, I guess, recognized by the medical community in any significant way since that point. So this was kind of the first study that really came out. And I think, so that's what I want to do. Talk about this study, talk about the follow-up studies from the same group. And anybody who's treated fibromyalgia, they know that it's a very difficult problem to treat. It's sometimes feels impossible to treat, and we never get full resolution of symptoms. At least we don't right away. And so I think that's what is also important, is that we tend to treat fibromyalgia with multiple drugs. We stack drugs because we're trying to get the best effect we can. And we typically pair it with non-pharmacological treatments too. We know that there's a strong component with people's mood and their psychology. And so I think that's important. If this drug is affordable, if it's low risk, and it actually has an effect on a condition that is difficult to treat, I think we should take that seriously. So the first study was quite small. It was 10 patients. This was at Stanford. They did 2 weeks with placebo, followed with 8 weeks, 4.5 milligrams of the low dose naltrexone, and then followed with 2 weeks of without the drug. And what the study showed was a 30% reduction in symptoms. That was in pain, that was in fatigue and stress. What's kind of interesting, and you'll see that on the very last study, is that they showed that those who have elevated inflammatory markers, specifically ESR, was actually a predictor for positive response. And I'm going to talk more about that in a second. The second study was a follow-up from that, and they just basically did the same study but with more patients, and they had 31, and the results were the exact same, a 30% reduction. To me, getting a 30% reduction is actually quite a big deal, especially for fibromyalgia. So the next study they did, which I talked about in the last review that I did, and it was, there were some graphs there that I showed from that study, but basically it was a very similar study, but they wanted to follow these inflammatory markers. And what they showed was that it actually decreased them. And that's what it's showing, is that people's inflammation in their body is actually reducing. And they show the same things as the other studies, a subjective improvement in pain, mood, and satisfaction. Okay, so some practical considerations. As I mentioned, low-dose naltrexone is a compounded medication. So it's not something you can just prescribe and they can go pick it up at Weggy. That makes it a little more difficult. But if you find patients that you think you'd be willing to try this with, There is a compounding pharmacy, as we all know. It's Keystone, and you can call them and talk to them, and they will walk you through the process. And you'll even see I kind of highlighted one of their websites, and they do name a number of things here, which you take that as you want. But on the other side is this other pharmacy. It's a pharmacy, I believe, in New York. And I actually used this once for a patient, and it did work. It worked. And it's a little difficult sometimes when you're calling a pharmacy from another state and they're going to ship it to the patient. But the price here was very good, and that's why I went that route. If you're going to Keystone, the prices are probably double that. I have been told that if you call Keystone and you ask them, they may be able to get close to this price, or at least they may be able to match it. But on the right-hand side, this pharmacy, actually, that's for 90 tabs. So that's 3 months worth. So I think for a lot of people, if you're talking $15, $16 a month, that's pretty easily tolerated for a lot of people. They can afford that. Okay, so to kind of conclude that portion of the lecture, I'm just going to reemphasize the things that I mentioned at the beginning. It's a very low dose, 4.5 milligrams. That's typically given at night. It can be given in the morning, but we do this at night. It kind of minimizes some of those side effects. It treats chronic pain, fatigue, possibly mood, side effects, the vivid dreams. I haven't had anybody tell me that those vivid dreams were significant enough to stop the drug. And I know of one other physician, he's a PM&R doc in the community, who has prescribed this medication. And I asked him about it too, and he said that he's never had anybody, but it is there, and it's worth mentioning to patients. And then abdominal pain, nausea, and headaches, those are pretty typical side effects. And again, it's a compounded medication. My experience so far with Dr. Phillips, and we have tried to play with this with a few patients in his clinic, and the results were pretty underwhelming, to be honest. I have had success with some patients but these are maybe 10 patients that I've seen with it. And I've had other physicians in the community tell me that it's worked quite well. I think one of the challenges is that when we are seeing patients in the clinic or in the inpatient setting, they have a lot of pain. Their pain's very high. We're treating it with very high doses of opioids at times. And so if you're starting low dose naltrexone, you really can't be starting an opioid. And so that it is for a select type of patient, one that you're not wanting to start an opioid, or they don't want to start an opioid, but one that you still need to treat for pain. And so you have to select the patient, one with a little lower pain. So I think, for a patient that maybe is older or even quite younger, where you don't want to start an opioid, or you're nervous about starting an opioid, this might be worth trying initially. And it does typically take a couple weeks for it to get full effect. Some of the literature has talked about dosing. There was a study that I found where it's kind of a complex way of giving certain doses to patients, but essentially it was a randomized way of dosing patients, and through that process they found that this 4.5 milligrams was the ideal dose. You can get as high as 6 milligrams. You can start as low as 0.5 milligram. I haven't seen any success with that low. You can start people just on the 4.5 if you want, or you could start somebody on a 3 milligram, and then in a couple of weeks bump it up to 4.5. Okay, so that's low dose naltrexone. The next topic I want to talk about is tricyclic antidepressants. The reason why I wanted to talk about this is because I see them everywhere. When I was a med student, I remember them giving lectures on tricyclics, and they were not. They seemed like they were kind of the boogeyman. They were bad drugs. They weren't specific. They had a lot of side effects, cardiovascular, and all these other things. And then when I got to actual clinical practice, I realized that they're everywhere. And I was kind of confused by that. I thought these were bad drugs. Why are we still prescribing them? And talking to physicians and diving into the topic a little deeper, what I came to realize was the dosing is so different. And that's really what's important. I think these were some of the first drugs that came out for depression. They've obviously been replaced now with SSRIs, but the dose back then was much higher, well over 100 milligrams. We're talking closer to 2 and plus. And that's probably why it got a bad name. And so that's why I thought it'd be important to talk about. And there's some things that I've learned since then that I want to talk to the group about based on my own experience. So tricyclic antidepressants, they work through norepinephrine and serotonin, just like our SNRIs. And that's how they treat depression. That's how they treat pain. SNRIs are pretty good at treating pain, and tricyclics are too. They also do a few other things. And this is where all the side effects come from. And we're going to talk about this. It blocks histamine, alpha adrenergic, and muscarinic receptors. When you look up tricyclics, you will find that they treat a number of things, which I find kind of interesting. Of course, chronic pain. It may treat mood if you're at a high enough dose. I think a lot of us have seen it used for neuropathic pain, and it is quite effective for that. It can be used for headaches. I've had patients on quite low doses, on a nightly dose of a tricyclic for chronic headaches, and it works quite well. It can be used for cyclic vomiting syndrome, which is interesting. A lot of times in the hospital, we get people who we treat for nausea. And by the time we're seeing them, we've already got all the other drugs on, the Zofrans, the Copazines, the Phenergans. And so we have to get creative and find other drugs. I don't think that tricyclics are necessarily second line. There are Zyprexa, there's other drugs that I would reach to. But if you've been doing palliative or hospice long enough, you do realize that patients, you start looking at third or even fourth line drugs. And so that's where tricyclics may become helpful, because they are taken you can take them daily. And they may treat other things than just that nausea. So what about dose? So I find personally that doses that are below 75 milligrams probably are best. They do seem to avoid side effects. And to be quite honest with you, I try to keep my doses between 10 and 25. If I'm starting to move up to 50 milligrams, that's when I'm asking about side effects more, because that's where I've seen them come at. One of the side effects that I find is one of the most challenging is sedation. And some people have told me that it's pretty profound. You know, they wake up the next morning and it's hard to get up and move, and they feel foggy. So let's talk a little bit about some of those side effects. And as I mentioned, it's all about the pharmacology. So these side effects, if you understand your pharmacology, you'll understand the side effects. The cholinergic one, we see this in the meds that we use. Blurred vision is one that I've seen. Constipation, dry mouth, possibly confusion, urinary retention, and tachycardia. If you're having a patient who's on opioids, who's on tricyclics, who's on other meds, and they're constipated, you may want to look at the dose of this medication. You may even want to consider getting them off of it. Through the alpha-1 adrenergic receptors, it can cause hypotension, orthostatic hypotension, and dizziness. That's really important, I think, for at least our older patients who are at risk for falls. Through the histamine blockage, this is sedation, increased appetite, weight gain, confusion. I've never seen weight gain. I've never seen appetite, increased appetite. That may be a dose-dependent side effect, but like I said, I have seen sedation. And I've even seen it at fairly low doses. I've seen it at as low as 25 milligrams. And particularly I'm talking about amitriptyline. And so I wanted to talk, my next slide will talk a little bit about that. But I do want to just finish this part and just say that there are other side effects. Some of the big ones are cardiac toxicity. But like I said earlier, I really think it's the dose. So if you're staying at 10 to 25 milligrams, you're unlikely to have a big effect on this. But it's worth noting and knowing about, particularly for some of our cancer patients where we're always concerned about QTc prolongation. They come in the hospital often, and they're having emesis and their electrolytes are not where they should be. And so this can be a big concern. So this is kind of why I wanted to talk about tricyclics, because over time I've developed a pretty strong opinion about which tricyclics I like. I hardly prescribe amitriptyline anymore. It's almost always nortriptyline. And I remember as a resident, I had found an article suggesting that the pharmacology of nortriptyline was different and it had less side effects. And I started asking physicians about this. And to be honest, not many physicians use nortriptyline. And I find that surprising. And now, since I've been using it as a resident, I have found that it actually does minimize side effects. And this was actually taken from one of the government websites discussing the two different between amitriptyline and nortriptyline. I found a Canadian Family Medicine article. This was back in 2018, and they asked the question, basically, is nortriptyline safer than amitriptyline? There was a Cochrane review on this, and you know, if you've ever read their reviews, they don't really say anything's true unless they really feel the evidence is there. And so they kind of gave a more nuanced opinion about it. My clinical experience is that nortriptyline does have less side effects, and that is because of the pharmacology. They're actually a little different. When you take amitriptyline, it gets converted to nortriptyline. And amitriptyline is a tertiary amine, whereas nortriptyline is the actual chemistry is a little different. And so that's likely where that the difference in side effects comes in. When I have a patient in the hospital and they're very anxious, they're not sleeping well, and they've got a lot of pain, I may elect for amitriptyline at that point. And that really is just to try to calm them down, to get that other effect. But I don't typically start these drugs in older patients because of the risk for falls. But I do find that nortriptyline does mitigate a lot of these side effects. And one of the things that I think we should take seriously is when we see patients, we know that pain is hard to treat. And over time, these patients begin to have multiple drugs stacked because we're trying to treat pain from different avenues. And I have real serious concern that sometimes we cause a lot of side effects that we're not even aware of. You know, I had a patient recently who was on a number of medications for pain, severe pain, and all he did was lay in bed. And I told him, maybe we are not getting the effect that we want from these drugs. Maybe we ought to actually pull back on some of these drugs to get you moving more. That's going to be your best treatment. And that's hard to convince patients of that. But I think if you tell them about side effects, most people do recognize that is a real thing. And most people want to get off drugs. They want to get off more meds. And so possibly either you get them off some meds or maybe you switch them from amitriptyline to nortriptyline and see if it helps. The pain relieving effects appears to be the exact same. So for me, there doesn't seem to be a good reason to keep people on amitriptyline unless you're looking for some of that sedation. You're looking to help them with sleep at night and maybe anxiety. Okay, next topic is going to be on NSAIDs. This is a topic that I see NSAIDs are typically, we use them a ton. I mean, you can buy them over the counter, and yet in the hospital, we seem to be so afraid to use them. And so I think it's a good topic to discuss because they're everywhere and patients are going to ask about them. And they have good effects, at least, and particularly maybe not using them chronically, but using them in the acute setting, they can be quite helpful. And we know that pain kind of oscillates. And so it may be something that a patient can take home with them and use when their pain is high. So let's talk about this because I found this really great article. It's called Acute Pain Management Pearls, a focused review for the hospital clinician. And this was number 3. It said there are tremendous benefits to employing anti-inflammatories or NSAIDs and a few good reasons to withhold them in the management of acute pain. Most of us know from med school or PA or MP school, like NSAIDs primarily, they work through inhibiting an enzyme. It's COX enzyme. There's 1 and 2, and that enzyme produces prostaglandins. Prostaglandins mediate inflammation and pain and swelling and fever. And so when we give an NSAID, we're blocking that process. So we're actually, for some, we are treating the kind of the underlying process for a lot of them. And that's what I think is really helpful about NSAIDs. But as we know, NSAIDs come with a ton of side effects. And if taken long enough, high enough dose with patients that are at risk for some of these things, they can be quite serious side effects. So that's what I want to talk a little bit about. And then I'm going to talk about, can we find specific NSAIDs that may be better for treating specific problems? So as we mentioned, if you understand the process of the enzyme, the COX enzyme that it blocks, you kind of understand everything about the drug. You understand how its side effects occur. GI side effects, there's cardiac, and then there's renal. So let's talk about GI side effects real quick. Of course, we know about ulcers and bleeding. Again, that's through the blockage of COX-1 inhibitor or enzyme, which then prevents the production of prostaglandins. Prostaglandins are important for protecting the stomach lining. So it produces mucus and bicarbonate, which helps kind of reduce the acidity of the stomach. You may not know this though, but also NSAIDs may actually increase acid production. And so not only is it preventing the production of bicarbonate, but it actually may be increasing, or I guess decreasing the pH through the production of more gastric acid secretion. It also has some direct irritant effects. So just kind of sitting in the stomach can be irritating. And then of course we know that it affects bleeding through platelet aggregation, and that can put people at risk for bleeding. And so if they were to develop an ulcer, they would also they would bleed easier. How do we mitigate some of these side effects? So some of you are aware that there are drugs out there that specifically try to address this. This is selective COX-2 inhibitors. Celebrex is the one that I primarily use. I think most of us know about Vioxx and the history of that drug and how they pulled it off. And we can talk a little bit about that here soon. But these really just block that COX-2 inhibitor. And so they were made specifically to hopefully mitigate some of these GI side effects for those that are at risk. Other things that we need to consider are risk factors. So of course, age. Do they have a history of ulcers? If they have a history of ulcers, you're probably not going to want to start the drug. Or at least you may want to do it short-term and the lowest dose possible. What are the other medications are they on? I just had a patient 2 weeks ago who was on steroids and NSAIDs. And I thought, that's a big no-no. Why would you do that when steroids are so effective? So if you avoid that. The other things we can do is we can start PPIs. And you can do that in the short term while you're given NSAIDs. And that is generally what's done in the hospital. The other things is you can use topical formulations. And I think that's one thing that is forgotten about a lot. Voltaren, diclofenac gel is very good at treating osteoarthritis in the knee. It's particularly I think in the knee because the medicine is able to get into the space of the knee much easier than other joints, other parts of the body. So the other two effects that I wanted to mention was cardiovascular. This is those who it increases risk of heart attacks, stroke. It can increase blood pressure. That's important to know. And for patients who have heart failure, it can increase fluid retention and swelling. And so if somebody's coming in with a heart failure exacerbation, either check if they're on NSAIDs or don't start NSAIDs while they're in there. And it affects obviously platelets and clotting, and that could increase some of this risk. So these, as I mentioned earlier too, Vioxx, it was taken off the market because of it's a COX-2 inhibitor. It was meant to protect people from developing ulcers, but what they found is that there may have been more cardiovascular side effects. So it was pulled off the market. And so that's important. If you're going, we're going to talk about this. I have a slide on this, but you may want to choose specific ones for these patients. The other one is renal effects. If somebody's got poor kidney function, you don't want to start an NSAID, or at least you want to, like I said, do a small dose in a short period, and you'd want to watch their kidney function pretty closely. So this is continuing with the same article that I mentioned at the beginning. I picked 4 of these issues that are kind of related to some of the things we've been talking about. And so I hope they give some insight into us for us when we should and shouldn't use it. First one is bleeding or antiplatelet effects. So the evidence shows that bleeding times, preoperative bleeding events are not significantly affected by NSAIDs at usual doses. So short term, less than 7 days, does not increase GI complications. And then, as I mentioned, COX-2 inhibitors can mitigate these effects. So the recommendation is do not hold NSAIDs for acute pain due to bleeding concerns if the usual doses for short, if used for usual doses for short durations. And then you can also consider a COX-2 inhibitor or something like a PPI for those high-risk patients. The other one is wound healing for orthopedic or spinal fractures or fusion surgery. When it comes to orthopedic surgeries, I have been told by orthopedics that if an orthopedic surgeon is not allowing you to use an NSAID, they're not up to date on the evidence. But I will say that if I have any neurosurgery patients, I never start NSAIDs because there seems to still be a lot of concern about it. And this is really from old studies. As you'll see, a lot of these studies were animal studies, and they had people concerned that it may affect the wound healing. But newer studies have shown that that is not the reality. The next one is major cardiovascular events after cardiac surgery. These COX-2 inhibitors have increased rates of cardiac events after surgery. And so their recommendation is to avoid specifically COX-2 inhibitors in cardiac surgery, use non-selective NSAIDs, and some selective COX-2 are safe and not. Oh, so they're basically saying, yeah, do not use it in cardiac surgeries, particularly. So I think that's one of those things where you want to be careful about. The other one is large doses must be used for analgesia. I included this because I remember as a resident, I found an article. It was in the ER, and they were using Toradol, and they asked the question: does the dose of a 10 milligram Toradol IV differ from the higher doses of up to 60 milligrams? And they showed in that study it did not. And I've seen other studies since then that have shown the same thing. And there are other places where I've seen physicians talk about ibuprofen, and they refer to studies that show that a 400 milligram dose is likely just as effective as a 6 or an 8. And so when we're talking about using NSAIDs, we're talking about short duration, lower dose. Try the low dose. Don't jump to higher doses. I think a lot of people, I know at least in my experience, they want the 600 or 800 milligram dose of ibuprofen. They feel that it works better. And I think that may be more of a psychological thing. You're likely going to get similar effects, but you're going to reduce those side effects. And I think that's what's important. And that's what the evidence has shown. So I want to kind of quickly go over some specific uses for NSAIDs. Diclofenac has been pretty clearly shown to be probably the best NSAID for knee arthritis. And that's why they probably put it in the gel. That's why Voltaren gel is used. Ibuprofen can be used for menstrual pain. I don't see a lot of that in the hospital. At least we don't ask about it, but maybe that's something worth considering. Naproxen is a drug that I haven't particularly used that much. I have found the effects not to be as good as others, but I will say, admittedly, a lot of other docs have told me they like naproxen. It's got a long half-life, which is great, 12 hours, so you can dose it twice a day. And it has been shown to be helpful with other like arthritis and rheumatoid arthritis. COX-2 inhibitor, Celebrex. I use this because you can dose it once or twice a day. I typically go 100 to 200 milligrams once or twice a day, and it seems to work pretty well. Indomethacin, gout, headaches, and then again, Toradol, short-term pain management. I have seen some conversations about Toradol and whether the IV versus the oral, if there's a difference. And generally, what I've seen is they say there may not be a difference, but also admittedly in practice, I have had people tell me that there is a difference. And I actually had a resident friend of mine who was in the ER. He got a dose of IV Toradol, and he said it was the only thing that treated him that significantly. So I'm not sure. The jury is out yet on that topic. Okay, so my next conversation, prodrugs and SSRIs. I think this is a very interesting topic. I found this study for an article review we did with our team at Trinity. And they're basically using an AI model to filter through people's electronic health records And they were asking this very specific question. If you're on an SSRI and you're also on a specifically pro-drug opioids, is there a difference in pain? So they had some patients on SSRIs, some not on SSRIs, some on pro-drug opioids, and some on non-pro-drug opioids. And they followed these patients for, at the time of right after surgery, at 3 weeks and 8 weeks. I want to ask the team, you don't have to answer this, but I want you to think about which drugs, the pain drugs we use, are considered pro-drugs. A pro-drug is one that needs to be converted into its active ingredient, or its active metabolite. Okay, so if you thought about some, I think, we all know that codeine is a pro-drug, tramadol is a pro-drug, but I did not know this. Hydrocodone is a pro-drug. That's what's in Norco. And I don't think I realized that because it seems that the effects of hydrocodone are pretty consistent across the board, whereas codeine and tramadol are not. Some people get great effects and some people get poor effects. We're going to talk about tramadol and the reasons for that in a little bit, but hydrocodone appears to have pretty consistent results. So the question is, why did they ask this question? Well, SSRIs block an enzyme that allows our body to convert hydrocodone into its active metabolite. And so theoretically, you would think that if you're on an SSRI, it may reduce the effects of hydrocodone. So it's a very interesting question. And like I said, they're using AI. This is a lot like ChatGPT. They're using something called natural language, I think, algorithms or something similar to that. And so very similar to stuff like ChatGPT, but it's not nearly as complex, and it's used to ask very specific questions. And so I think we're going to see more of this in the future. And we had a lecture on this just a couple of months ago, which was a very interesting lecture. And I do think that this type of using AI in medicine is going to be the standard of practice here soon. So let's talk about this. What was the findings? They found that depressed patients who are SSRIs do get reduced effects, that their pain at 3 weeks, at 8 weeks is higher. The pain scores are higher than those who are not on SSRIs and Norco. Okay, so when you're going to see a patient, you should look through their medications. Are they on an SSRI? Norco is prescribed by so many people in the hospital. I think it's probably one of the more popular pain medications because it's a combination pain. It has hydrocodone and it has Tylenol or acetaminophen. So I think a couple things. If you see somebody is on that, maybe they shouldn't be on a Norco. Or maybe you just realize that they need a bigger dose. If you're talking to that patient, they say Norco has worked for me, but it just, I've generally taken a little larger dose than what you typically would expect. Well, now you know why, and you have a good explanation for that. And I think that will help you in the future. But maybe when you see that patient, you also get them off of Norco and you just start them on a non-pro drug like oxycodone or morphine or something else. Like I said earlier at the beginning, part of our job is to be able to add something to the pain management that other physicians may not know about. And I think it's more than just increasing a dose or increasing the frequency. It's about these little tricks that you can do to try to really maximize somebody's pain management. So now that we're on the topic of prodrugs, I thought it would be helpful to talk about tramadol. Gosh, I feel like tramadol, people have a lot of strong opinions. I've listened to a number of podcasts from physicians in Canada and Australia, and people, they tend to kind of not like the drug. Though I've seen a lot of physicians, even in this community, use it. And I think tramadol, actually, the pharmacology of it is very interesting. And I'm surprised we don't have more drugs like tramadol. And I think partly is because some of the effects are not very strong for a lot of people. And so that's maybe why. But I do like the idea of tramadol. It's kind of works like an SNRI, but it also kind of binds to some of these mu receptors. So it does honestly feel like one of these drugs that's in between, say, something like an NSAID or an SNRI, and in between that and an opioid. It kind of exists in the middle. But I think what we find in clinical practice is that some people get really good effect, and then other people get really no effect at all. And my general experience is that more people get less effect than I would be hoping for. How does tramadol work? It is a prodrug, just like hydrocodone, just like codeine. So it gets converted into its active metabolite. And because of that, some people have different levels of that specific enzyme. And that's where the effects come in. So as I mentioned, it affects neurotransmitters like norepinephrine. It affects serotonin. It's the norepinephrine is primarily probably where it gets a lot of its pain relieving effects, but it also has this mu opioid. It binds to the mu opioid. When you're a slow metabolizer, you're not converting it into its active metabolite, and you're not getting any effect. I found it difficult. I tried to do some research to figure out, do we know anything about people who are slow metabolizers versus fast metabolizers? Do we have numbers based on studies? And I have seen numbers. I think it's very difficult though, right? Because if you get a number, say one of the numbers I saw was Caucasians, there's about 10% of the people are slow metabolizers. And then they talked about the fast metabolizers. They said people of North African descent are about 30% can be a fast metabolizer, meaning that they get better effect. But what do you do with that information? Unless you're actually testing for that enzyme, which I have never done. I'm not even sure how to do that. That doesn't really help you. So I think for me, what does that mean when I see a patient? For some people will say, don't even start the drug because you're not sure how they're going to be affected by it. Just do something like morphine or oxycodone because the effects are very clear. They're consistent. Well, I don't know. I mean, I think the argument can be made that maybe you just need to try it and see how they do. If you think they're a good candidate, try it. If not, then move on and try a different drug. I think some, at least in the palliative and the hospice world, will say that no, and I have seen those recommendations that don't even try it, just move to morphine, more consistent results. I'm not sure of the answer. I guess it really is patient dependent. I want to talk a little bit about the risk of tramadol too, because these are some important topics, and I'm going to reference some studies. I see that we got about 10 more minutes here. Seizures are a big concern. If you're on other drugs, if you have a history of seizures or epilepsy, you want to be careful with this. I've never seen anybody, I've only seen one patient who had a seizure on these drugs, and they abused them. They were taking more than they should. Serotonin syndrome, if you're on multiple serotonergic drugs, you got to be careful. I do wonder sometimes if some of the side effects that people have or the complaints they have are because we're kind of stacking some of these drugs and they may be getting some weak serotonergic side effects. Dependence and abuses, obviously. I have had one patient tell me that it felt like a very strong opioid to them. And so there can be that concern. Other effects that we should be aware of: nausea, dizziness, constipation, drowsiness. These come with any pain meds for the most part. So I got 3 studies I want to talk about. I'll kind of go through them quickly. It's just to highlight some of the other effects. I was surprised. This is what I learned a couple of years ago when I was in the fellowship, was that when you start somebody on tramadol, they have a higher risk for coming back to the ER and having falls in that 1 month period. And so I think this is a real concern that we need to be aware of. And this may be related to hypoglycemia. And what the studies have shown, this was actually a JAMA article done just, I think, about 5 years ago. And this low blood sugar was an effect even if you weren't diabetic. And so it's hard to tell. And so when you're starting tramadol in an older patient, you got to be careful, because if they fall and they have a hip fracture, that could lead, we all know the prognosis for a hip fracture at an older age. It can be really horrible. So we got to be careful about that. We got to watch people. If you're in the hospital and we're checking these things, I think that's a safer place to start tramadol. These are some other studies. This is one that talked about older adults with post-traumatic osteoarthritis. And they found that hip fractures, that tramadol was associated with a significantly higher risk of hip fractures. These were for patients that were particularly older than 60 years old. Another interesting thing they found was that it was higher in male patients. So we have to be careful about that. Now, I brought this study in here too because I wanted to be realistic about tramadol. There are some serious side effects with tramadol, but at the same time, opioids have them too. And if you look at this study, you'll see that opioids actually appear to be a little higher risk in a lot of these things that they're looking at. Higher ER visits, higher falls and hip fractures. That probably shouldn't surprise us. Higher cardiovascular hospitalizations. You look at the all-cause mortality, and they probably are equal or tramadol's a little higher. So, I think tramadol is useful. If you find a patient who's been on it and it does well, continue it. That's the patient you want to continue. But if you're going to start it with somebody, just be careful. Make sure you're picking the right patient and make sure you educate them on these things. Okay, I'm running out of time, so I'm going to kind of go through this quickly. But these are some topics. I find this very interesting, non-pharmacological treatments. We've touched on this in some of the original lectures with Dr. Mulder. And I think the way we think about pain, the frameworks we use is so important. If we use just this kind of biomedical approach, we're just going to be going after drugs. And that is going to miss so much of the helpful treatments that we have. In palliative care, when we're in the hospital, we're talking with our chaplains and talking with the other teams and our social workers, we commonly talk about total pain. And that is pain that is not just mechanical, not just biological, but it's also psychological. And we know that these things can be affected by social concerns too. People's histories of trauma, the stress that they're in, the environment that they're living in. And so it's really important that we take we have a specific framework for how we address pain. If you're interested in a little bit of the history of this George Engel wrote an article in 1977 that really, he's known for kind of studying this biopsychosocial model in medicine. And he specifically said, we need to think about humans as humans. It's really more of just a holistic approach. And I think that's important. I'm going to move on. This is a book. If you were to go to Mary Free Bed, there are some posters up. I haven't been over there in a few years, so maybe they're not there anymore. But when I was there were some really interesting posters up about pain management. They have a whole program designed for this type of approach, one that tries to actually get people off drugs and tries to help them understand, educate them about how pain is affected by more than just a nerve that's being pinched. That's just the beginning of the story. This is a book I recommend it to people. I think it's a very cool way of presenting pain management for physicians and understanding the complexity of pain and why pain is more than just pain receptors. And this book and a lot of these other type of people who approach pain this way, one of the key points that they try to point out is that pain is really about protecting oneself. And so it's not just about the signal coming from the broken leg. It's chronic back pain, things like that. There are more things there are more inputs than just that nerve, that nociceptive nerve. This is more here about basically these nociceptive pain receptors. This experiment kind of was showing that pain is more than just that signal. That once that signal comes to the brain, there are multiple filters that goes through, and pain can be affected by stress. It can be affected by past trauma. It can be affected by anxiety. And so the input is from the nociceptive receptors, but the output is pain. And there are a lot of things that to get that output, it must go through to produce pain. So Mayor Free Bed, they have a whole clinic on this. I think this is such a fantastic clinic and approach, and not many communities have access to this. So I encourage new fellows, other people on the call, like, this is an incredible resource. We should use it. They use psychologists, occupational therapists, they use PT and education. And one of the things that they are actively trying to do is get people off some of these drugs so they can be more functional. And they talk about how we could speak about pain in different ways so that we can do the things we love and not be so burdened by chronic pain. This was an article written by Dr. Hudson back in 2019. He was the one who kind of started the clinic. He's not there anymore, but very interesting. It's through the, I think it was the Washington Post. And he really talks about some of the things we've mentioned, that the idea of pain management has evolved quite a bit, and that even the education of pain management hasn't really caught up yet. And so med school, we're kind of still taught this biomedical approach. And we're taught about which meds we can use to treat pain, but we're rarely taught how pain is actually much more complex. And so he's making the argument that we need to not only educate our physicians and our providers, but we also need to educate patients. This is just, I thought was another interesting portion of that. He talks about a train and how if you're living next to the train and you're hearing it every day, most of the time, those people are going to just kind of forget about that sound. But if you, every time that train came by and you were focused on that, just like pain, if you're always focused on that pain and you're not thinking about something else, that pain's going to be worse than what it is. We call that catastrophizing sometimes. It's another physician here actually in the community, Dr. Schubiner. He's in Southfield. He wrote this book. You can get it on Amazon. It's a 28-day kind of program that they can write in it. And he uses a lot of these other techniques, meditation, journaling, education. So I think it's a really neat thing. I've actually have the book if anybody wants to take a look at it. Lastly, there is an app. It's called Curable. It's been out for a number of years, and it uses all these same techniques, but they can have it on their phone. And what's neat is, like, say you're in an acute exacerbation, you can go on and they'll actually try to kind of help walk you through that a little bit. And what was interesting is I went on this website recently, and this guy, Dr. Schubiner, is actually one of the medical people on the team. So I find that very interesting. So thank you very much. That's the end. These are some citations, and I appreciate you guys being a part of this conversation. I think we can, I know we're kind of a little later. I don't know if there's any questions that I can help answer quickly.
Yeah. So thanks so much, Brett. Great job on this. Interesting things that we should keep in mind. And I appreciated. I was really curious. So I had always, my own mind, equated hydrocodone and oxycodone as pretty much same church, different pew. Just cousins working on the same receptors. They had similar doses, but it sounds like the hydro is a prodrug, oxy would not, so they may have different effects on the same person, or different effects in different people. Is that correct?
Yeah, actually, I think that's an interesting point, because when you look at like opioid conversions, a lot of times I see different conversions. Sometimes it's a 1-to-1. Usually, though, I will see that oxycodone is a little more potent by about 25%. When I talked to Dr. Taylor Cordonier, one of our physicians at Trinity Health, he shared with me that in residency, they always equated them as a 1-to-1.
That's the way I learned it too.
Yeah, so they're probably close. Yeah.
I had a patient that came into clinic many years ago, and this has happened more than once, who had been on Norco for relief of their pain. Their primary was concerned about that, so switched them to Oxy. Why the PCP would think that one would be better than the other from an opioid exposure perspective, I really don't know. But I've had a couple of circumstances in which the Oxy was not as effective as the Norco was. My rationale for that was that they had an opioid resistant pain that was actually responding to the acetaminophen. And so that's sort of what I have gone on when I've seen that particular kind of a picture. But it makes me wonder if maybe there is a pharmacogenomic issue. And you talked about some of these, the conversion issues. We've known about codeine, I think, the best and the longest, but I was not aware of that for hydrocodone or tramadol. Methadone is another one that can be significantly influenced by your genomic makeup. So it'll be really interesting 10 years from now to see how we are analyzing individuals' opioid needs on the basis of their genomic makeup.
Yeah, I think that's I wonder if that'll be part of the future, and we'll be getting kind of workups on people, and then I imagine we'll be using some of these, AI systems to help kind of stratify patients and kind of figure out maybe if one drug might be more effective than another. Um, I find this
Sure.
stuff quite interesting because I think, as we all know, like pain is complex, and it's like uh, we can try different doses, different drugs. Sometimes one get one effect here, and another times it gets effect there. And I think that just is because people's metabolisms are different, and there's a lot of things that go into this than more than just than what we think.
Well, thanks again. Great job.